Hello, this is Dr. Paul Sachs. I'm Clinical Director of the HIV program in the Division of Infectious Diseases at Brigham and Women's Hospital, and also an Associate Professor of Medicine at Harvard Medical School. Today I'd like to summarize some of the recent changes that occurred in the Department of Health and Human Services guidelines for treatment of HIV infection in adult and adolescents. These changes occurred on the 3rd of November 2008, and a few of them are important for clinical practice. The first of these is the inclusion of darunavir-ritonavir as a preferred initial protease inhibitor option for treatment-naive patients. Darunavir-ritonavir already has an excellent track record in treatment-experienced patients and has become the de facto protease inhibitor of choice for those who have protease inhibitor resistance. In treatment-naive patients, using a different dose of 800 milligrams of darunavir and 100 milligrams ritonavir, it was non-inferior to lopinavir-ritonavir in a prospective comparative clinical trial. In addition, 96-week data recently presented at ICAC suggests it might be somewhat more effective. This 400 milligram tablet of darunavir was just approved by the FDA, so one can now prescribe 800 milligrams of darunavir and 100 milligrams of ritonavir once daily for this patient population. In addition, lopinavir-ritonavir is now listed as preferred in its once-daily dosing option, again based on a prospective clinical trial that showed that it was non-inferior to the twice-daily option. A third change is the moving of abacavir-lamivudine to an alternative category for initial nucleoside analogs. This move was based on the results of ACTG 5202, which showed a higher rate of virologic failure in patients who had screening viral loads greater than 100,000 copies when compared with tenofovir M-tricytidine. In addition, there have been a couple of cohort studies that suggest a possible association between abacavir use and an increased risk of cardiovascular disease. Importantly, alternative options for therapy in the guidelines may be preferred for individual patients. So, for example, a patient with pre-existing renal disease should probably be treated with abacavir-lamivudine and not tenofovir M-tricytidine. Other changes to the guidelines include a section on regimen simplification, where in particular patients who have been prescribed therapies that were perhaps standard of care 5 or 6 years ago but are no longer considered such can be switched to more current and updated regimens. Another change is the inclusion of a section on transitioning adolescents to adult care, sometimes a very challenging thing to do. These guidelines were updated frequently, and I encourage you to look at the full set of guidelines, which are extensively referenced and available for free at aidsinfo.nih.gov. Thanks very much for your attention, and happy holidays.